Good afternoon. My topic for this afternoon is preconception care, the role of the physician. And I would like to thank the organizers for this opportunity. The outline of my talk would include making the case for preconception care by a physician, defining preconception care and the need, describing the components of preconception care, and looking at suggested recommendations for implementation of preconception care. I'll start by making a case for this. In our experience as a medical unit treating medical disorders in pregnancy, this is one of our patients, 18-year-old Mrs. C, a known case of rheumatic heart disease with a history of moderate mitral stenosis, came to us at 16 weeks of gestational age. She had been pregnant previously and had been detected to have rheumatic heart disease at that instance. She presented this time with dyspnea on exertion, class 2 symptoms, with exertional palpitations, and on examination, there was no pallor, there were no features of cardiac failure, and her cardiovascular system examination revealed features of a mitral stenosis. The echo for this patient showed a severe mitral stenosis. Now, what we know with severe mitral stenosis in pregnancy, the chances of pulmonary edema are 37%, new or recurrent arrhythmias 16%, and maternal mortality of 3%. Now, if you look in pregnancy for the modified WHO risk class, this is a class 4 lesion, which is associated with extremely high risk of maternal mortality or severe morbidity. Pregnancy is contraindicated. And if a woman presents a lesion in this class early in pregnancy, termination should be discussed. And if pregnancy is terminated, choices of an intervention prior to the next conception to be offered. So at 26 weeks of gestation, she underwent a transfemoral balloon mitral valvotomy for worsening of symptoms and delivered a single live baby boy at 36 weeks by normal delivery. What this successful delivery involved, however, was 25 hospital department visits for all departments, an extra admission before the one for delivery, a procedure with potential risk to mother and child, unaccounted stress, both physical and psychological, to her and her family, expenditure beyond a usual pregnancy, and though not usually included, stress on the hospital system to ensure safety of the mother and baby. Ideally, she should have had a risk stratification, counseling about the use of medications like ACE inhibitors and ARBs, which are potentially teratogenic, and valve intervention prior to the conception. So preconception counseling or care, which is PCC, is defined as interventions that aim to identify and modify risks, biomedical, behavioral, social, to a woman's health or pregnancy outcome through prevention and management. This is as defined by the CDC in 2006. So how does this concept apply to a physician's practice? We look at some thoughts and evidence. In this very interesting article in ACP Internus, American College of Physicians Journal, it looks at making space for preconception counseling. A very interesting quote, however, is what they say: as internal medicine physicians, we deal with a lot of these complications after the postpartum period. There's many reasons why the mortality rate is so bad, but if we could help at least one part, it would be that we can provide better care even before the women get pregnant. This article also discusses asking all our women patients if they plan to get pregnant, and if so, when. Remembering that if there's a medication, we can stop it. Get a full history, look at complications in prior pregnancies, and remembering that pregnancy is the ultimate stress test for cardiovascular health, and any cardiovascular problem in pregnancy can affect future health. Another interesting article in Preconception Healthcare, What Women Know and Believe. This was published in Maternal and Child Health Journal. If you look interestingly, almost 66% of the women wanted a preconception counseling. Before they tried to become pregnant, 75%, and from what source? Most of them wanted it from their primary care physician. I'd like to also point out that planned pregnancies were there only in 47.2% of the study population. Now, why is the physician involved then? So the concept of PCC is of counseling at least 6 to 12 months prior to conception. This falls under the purview of the medical professionals looking after health conditions of women in reproductive age group, but prior to pregnancy. Such a concept is still in infancy stage in India. In addition to the need and the apparent lacunae, There are additional truths. Pregnancies are usually unplanned. Major healthcare indices for the country are dependent on preconception care. The prenatal or the first trimester of pregnancy is not when all pre-existing disease conditions should be accounted for. So let's look at pregnancy and planning. These are statistics from the Lancet Global Health. This was a study done in India in 2015 looking at incidence of abortion and unintended pregnancy. When you look at this part of the graph, you'll see that almost 70.1, there was an incidence rate of unintended or unplanned pregnancies. And in that, almost half ended in abortion. The same article also shows an interesting fact that if you look at planned births, 43%, all the rest of the half are unplanned, and in that, 1/3 of the pregnancies, 33% here, had induced abortions in the unplanned pregnancies. Looking at healthcare indices for our country that can relate to preconception care, the maternal mortality rate, just for remembering, is the number of maternal deaths per 1 lakh live births, and the infant mortality rate is the number of babies who died less than 1 year for 1,000 live births. This includes abortions. When you look at our country's history, this is the graph. We've been steadily coming down. The target is by 2030 to reach an MMR of less than 70. Maybe we could contribute to that a little bit with preconception care. Right now in 2014, India's contribution to global absolute maternal deaths was 1/5. What about the infant mortality rate? In 2018, as per the United Nations child mortality estimates, there are 7,21,000 infant deaths in that year, which means there were 1,975 infant deaths every day on an average in 2018. The trend is coming down, but the percentage drop is slowly reducing. And we would like that percentage, the gap between 2 years, to be more. We should bring down our infant mortality rate more. During this, I'd like to discuss our experience with the second patient. A 35-year-old lady at 8 weeks of gestation age with seizure disorder for the last 14 years. She's on the drugs mentioned. Now, what we know is that there's moderate or high risk of fetal harm on valproate, and actually oxcarbazepine levels go down in pregnancy. And she was not on folic acid. So most likely significant exposure has already occurred between the time of the missed period at 4 to 6 weeks and presentation to a prenatal or antenatal care in the first trimester. Serum alpha-fetoprotein was sent and a screening ultrasound was advised at 17 to 20 weeks for neural tube defects. This patient unfortunately had a spontaneous abortion. So ideally, there should have been counseling even prior to pregnancy about the anti-epileptic drugs. There should have been contraception advice. The risk of AEDs on pregnancy outcomes should have been seen, and possible changes needed to optimize the AED regimen for pregnancy should have thought of, along with folic acid supplementation to prevent neural tube defects. So what about these interventions in the prenatal or early antenatal period? It's in fact too late. The heart begins to beat at 22 days after conception, the neural tube closes by 28 days, and the palate fuses at 56 days. So any teratogenic effect is already happened, especially because a woman doesn't realize she's pregnant and she may be on harmful drugs. So it's not just physicians. If you look at this particular data from delivery strategies for preconception care, we should realize that we should look at every woman and every time and ask her this question. So in this particular study, you look at it's beyond physicians, the health system, the education system, and other platforms which also need to deliver preconception care in areas like screening and management of chronic diseases, nutrition optimization, infection prevention, nutritional counsel, and completion of secondary education for adolescent girls. The physician, of course, is involved in these first 4 areas. So when you look at Indian data, pregnancy outcome with risk factors, in this study, it was a population-based cross-sectional study, and it was actually published in BMC, Pregnancy and Childbirth, done in Nashik district in India. What we see is all of these outcomes, abortion, stillbirth, and low birth weight, all had pre-existing illness present in these women. There were other things, of course, including consanguinity, residence in a tribal area, and heavy work in the last 6 months of pregnancy. Another study looked at the prevalence of periconception risk factors for adverse pregnancy outcomes. These were done in urban Indian women. And if you look at this graph, you'll see that almost a quarter of the people had at least 5 risk factors. And if you look at the number of risk factors, more than half of these patients had at least between 4 to 6 risk factors. The risk factors being mentioned here. So what is the history of preconceptional care? ACOG, both in 1995 and 2005, published bulletins and a committee opinion on preconception care. The CDC in 2006, the WHO in 2013, the National Health Services in UK in 2015 to 2017, and finally in India, the Federation of Obstetrics and Gynecology Societies of India published it in 2016. Shown here, of course, is the preconception care policy brief from the WHO. So what are the components in preconception care? Giving, managing, avoiding. Give protection, manage chronic conditions, and avoid exposures to teratogens. The CDC in 2007 also encapsulated as risk assessment, health promotion, and interventions. I'm going ahead and looking at the recommendations to improved preconception care. It's adapted from the CDC guidelines 2006 and a bit of Foxy's inputs also. So these recommendations, which I'm going to next, just had 4 goals in mind. Improve the knowledge and attitude and behavior of both men and women related to preconception care, and assure that all women of childbearing age receive preconception care services and evidence-based screening, health promotion, and intervention. Reduce risks was the next goal by a previous adverse pregnancy outcomes to intervention in the interconception period. I won't dwell on that much. And to reduce the disparities in adverse pregnancy outcomes. So what were these recommendations? There are 10 recommendations, but I'll be concentrating on the ones that are relevant to the physicians, and I'll go through it one by one. Consumer awareness. I think this is the easiest thing to do by using information and tools which are appropriate across various ages, literacy, cultural and linguistic context. We can start increasing the public awareness. Preventive visits. So I would say a preventive visit is a visit of any lady who intends to become pregnant but is not yet pregnant, who comes to a medicine OPD with a health problem. And what we can do is provide the risk assessment and educational and health promotional counseling to all these women. So if you look at the history that a physician can do, you'll realize that there are 8 domains that a physician will anyway ask. Every woman, every time. Environmental hazard exposure and toxins, medications that are known teratogens. Look at nutrition, folic acid intake and weight management. Genetic conditions which will come in family history. Substance use, chronic diseases, especially diabetes, hypertension. Infectious disease and vaccination. Look at social and mental health concerns, including depression and domestic violence. I think these questions are easily done in our routine history taking. Now, interventions for identified risks. What we can do is increase the proportion of women who receive interventions and focus on high priority interventions, mainly those with evidence of effectiveness and greatest potential impact, which I'm going to discuss in the next few slides. Nutrition supplementation. Folic acid 0.5 mg or 400 microgram per day reduces the occurrences of neural tube defects given 3 to 6 months prior to conception. May need higher doses in certain special situations. I would say in our country, please do replace the vitamin D and vitamin B12, especially if they're vegans, though B12 supplementation can be given through pregnancy also. Optimizing weight in overweight and obese women to maintain a BMI of 18 to 23 kg per meter squared. And vaccinations. Hepatitis B for those at risk, rubella vaccination, but of course just to check if they've taken it earlier. And desirable, of course, is your influenza, and of late taking the vaccine against COVID-19. Tdap is also desirable. Chronic medical illness intervention mainly uses checking on drugs and control of the existing disease. Anti-epileptic drug use changed to a less teratogenic regimen. Diabetes, maintain HbA1c less than 7. Hypertension, avoid ACE and ARB, ACE inhibitors and ARBs, hypothyroidism, maintain a TSH of less than 2.5, SLE, greater than 6 months of quiescence on stable therapy, cardiac, as we discussed, interventions prior to pregnancy, and if on warfarin, especially greater than 5 mg, can switch to heparin. This kind of scenario will be discussed later in our clinical case discussions. Asthma, make sure it's fully controlled. Inhaled corticosteroids and beta-2 agonists are generally safe. For cancer, fertility preservation options prior to therapy. Look at infection screening. Can offer preconception screening for HIV, syphilis, and hepatitis B. And targeted screening, especially to the physician for tuberculosis if the history and examination is as such. A pre-pregnancy checkup is ideal. That means the lady knows they are going to attempt to conceive baby and come just before that. It may not happen. It's being done now in our institution with previous pregnancy loss, but we can target before the loss itself. So what about the men? Preparing men for fatherhood is a good thing. So anybody who accompanies a woman who's planning for a child, it's good to have a discussion together. It'll improve pregnancy outcomes and also help in family planning and offer an opportunity for disease prevention and health promotion in men. On a personal note, why does this matter to me? Well, the loss of a baby or a mother to a possible preventable situation does not seem fair and is totally unnecessary. The loss of a baby to a mother does add psychological and social stress. Our health resources and our country, unfortunately, is not adept at providing for babies born with deficiencies, and that's the truth. So the end of my talk, and hopefully the beginning of something new, is improving the knowledge, attitude, and behavior of persons, families, communities, and institutions for preconception care, and looking at something that could affect the future health of the woman, her child, her family, and at the end, the country. My resources include from CDC, the FOXY, from UK under the government services, and from WHO, among others. I would like to end by thanking all of you for your patient listening, for God's daily provisions, to the organizers, to my colleagues in my unit and the Department of Obstetrics, and to our patients who teach us new things every day. Thank you all again.